So I just want to get an idea about who's using 3D echo in mitral valve disease. So does anyone not have the machines in their hospital, not using it? You put up their hands. Does anyone have the machines but don't really see the point of it? Have tried it but never found it all that helpful or found it really difficult to do? Who's using more 3D in their clinical practice? And who uses it all the time? Great. So a mixture of everyone. So I'm going to talk to you about the use of 3D in mitral valve pathology and how I think it's really essential for your clinical practice, because it allows exact definition of pathology, mechanisms, and lesion localization. It also allows more accurate quantification of mitral regurgitation. And as Sean alluded to, degenerative mitral disease falls along a spectrum from simple fibroelastic deficiency to more complex valvular lesions in Barlows type valve. And the other really important thing we know is that the more complex the valve disease, the greater expertise needed of the surgical center looking after it, and 3D really allows us to triage this. It also allows better joint decision-making between the referring doctors to the surgeon and clear description of the type of pathology. And one of the really important things is that the literature shows that higher volume mitral valve surgeons and centers achieve better outcomes than lower ones. So this will probably be talked a little bit about later, but when we talk about mitral valve repair in severe mitral regurgitation, mitral valve repair is a class 2A indication in where the likelihood of successful repair is greater than 95%, with an expected mortality less than 1% when performed at a heart valve center of excellence. So this term gets talked about a lot, a center of excellence. So how can we define that? So where there are multidisciplinary experts in valvular heart disease, where the center offers contemporary management, so they can deal with complex valve repairs. They have transcatheter therapies for the people that may not be suitable for valve repair. They use modern diagnostic techniques. You'll be hearing a bit more later about CT, but also when you use 3D, that your surgeons and cardiologists are involved in national outcome registries, and they also report their outcomes as well. And this is something I think we can do better in Australia. So this slide is alluding to a very important point. So for the sonographers, the cardiologists, the cardiology trainees, who's been to cardiothoracic theatres and actually seen a mitral valve operation? So a few of you. So I would really encourage as many of you as possible to get to theatres, because you're looking at this pathology every single day, and then you need to actually see what it looks like in real life. And also get to know, as cardiologists, get to know about the type of operations available, because there are multiple operations available to our patients. On the upper right, we have an open sternotomy, so this is a more traditional approach to mitral valve surgery. On the bottom left, we have the robot, so the Da Vinci robot, where we get robotic mitral valve repair. We can see here the surgeon is actually operating separate to the operating theatre in the same theatre. And then we're doing now more mini mitral valve repairs, where you have a thoracotomy incision and peripheral bypass. And for a referring cardiologist, it's really important that we be able to talk to our patients about the different types of operations, and often this will be dependent on the type of pathology. So the important point is that 3D echo allows more accurate both sensitivity, specificity in terms of detecting mitral valve pathology. And in one series, the findings of 3D echo altered the operative technique by over 25%. So using 3D, especially for people who are not experienced in echocardiography, allows greater accuracy in terms of description of lesions. So I think it's all really important that we all get familiar with this view, the surgeon's view of the mitral valve. And this has been the common presentation of images of the mitral valve in 3D. And Sean showed you what the pictures look like anatomically, where we have the anterior leaflet at the top of the picture, the posterior leaflet down the bottom. And this shows very nicely about how the anterior leaflet is much bigger than the posterior leaflet. And you have a very close association with the aortic mitral curtain. And this is how the surgical view is obtained at the time of surgery and how we represent it, because this is when the surgeon is operating the view that they expose the mitral valve in. and an intraoperative view of the mitral valve. And I think it's really, once again, really invaluable to be able to go to theatre. So this is the view I'd like to get really familiar with. So this is a really nice animation about the 3D view. So we have here a multiplanar reconstruction. So some of you were at the workshop earlier, saw how we get a multiplanar reconstruction where we post-process some of this imaging offline. And in the 60-degree view, the bicommissural view, we see very nicely a P2 prolapse. We're able to look at it at an orthogonal view of sort of 120, and then also see it very nicely on the 3D. The also nice thing about 3D allows us to look at the regurgent orifice area and actually look where the mitral regurgitation jet is coming from. So when we're talking about 3D echo modes, there are a couple of modes we need to become familiar with. So we have real-time, where we just press a button and turn it on. We have the mode where we multi-beat, where we create either full volume or full volume color, and when we're using biplane imaging as well. I'm going to briefly talk you through some of these modes. And 3D image resolution is a trade-off, but the sector size, our frame rate, and image resolution. And the really important point is that you need a really good quality 2D image before you get a good quality 3D image. So you need an optimal sector size, sufficient spatial resolution, and adequate frame rate as well. So the modes of acquisition. So our 3D live mode of acquisition is a fairly narrow sector and allows us to just turn on the button and see what's going on. This mode is really good to guide procedures in the left atrium. And for those of you that like pizza, if you like New York style pizza, this is a very thin section of the heart in a triangular shape. When we move on to our full volume, this is a much thicker pyramidal slice. It's like your Chicago-style deep dish pizza. It allows us to then go and analyze the data offline. Often when we're taking full volume, we need to take multiple beats. And a zoom mode is just focusing on one area of that full volume, and it's one of the most common modes that we look for very clear definition of valve structures. So the American Society of Echo has published guidelines for image acquisition and display. Not only do they talk about guidelines for the mitral valve, but also for other valves. So there is a uniform way of presenting this data. And I encourage you to look at this document. So let's start off going over these 3D modalities. Let's look at the XPlane. The XPlane is great because it provides excellent frame rate, color Doppler, and allows us lots of scanning planes. So this is an example of using the XPlane. Does anyone use XPlane on a regular basis? So it's on a lot of the machines, it's a really good feature. What I do with the XPlane is then I move my reference line and look at all the scallops, of the mitral valve while in the bicommissural view. And this is a nice example of both A2 and P2 prolapse. You can see that the age of the young man is a fairly young with a Barlows style valve. And you can look through the different scallops and see which scallops are prolapsing. So real-time 3D or narrow volume, it has a good frame rate. It's good for guiding procedures in left atrium, such as left atrial appendage occlusion or MitraClip. It's fairly easy, and you turn it on, and this is what it might look like. One of the important things about using this is you will not be able to image the whole mitral valve in one sector, and you may need to. You'll be parts of the anatomy that you will miss. Real-time 3D zoom is what we use a lot clinically. So this is best for valve morphology. It has good spatial resolution. It's got a reasonable frame rate and allows rapid and confident recognition of valve lesions. It is better for 2D toe for look at clefts, for commissural disease, which is often missed, and also leaflet perforation and vegetations. So this is an example from a day-to-day clinical practice. You can see the prolapsing leaflet come out towards us. Once again, the surgical view, left atrial appendage, the aortic valve up the top. So all of these valves will be presented in the surgeon's view orientation. So another example, this is of a valve perforation of the anterior mitral valve leaflet. One of the tricks here is that you need to be careful about your gain, that if you do either overgain or undergain, that you might make it look like a perforation when there's no perforation. This was a nice example of a perforation due to endocarditis of the anterior mitral valve leaflet. So full volume is where it can make really, really attractive looking pictures. One of the downsides is that you need to stitch together multiple beats. So people who are in atrial fibrillation, who have an irregular heart rate, lots of ectopics, you may not be able to do this. Also breathing makes it difficult. So what we do is we take multiple ECG cycles and create multiple sectors of information, and we get really beautiful pictures, we get really beautiful three-dimensional pictures like this with very good, very close detail. Here you see the posterior leaflet, you see some ruptured cords and a prolapsing, almost P3 segment. And also with full volume, you can do beautiful color 3D. Now, these can be challenging to do at first, but when you can slow down, you can often look at where the origin of the valve lesion is coming from. And you can see here that we're using full volume, and we often need multiple beats to get a good picture. So Sean talked a bit about the Carpentier system of valve, describing the valve morphology and also the level of dysfunction. And I think it's really important that whatever level of training that we are, to think about what is actually going on with this valve. And I don't think in 2017 it's good enough to just to describe that there is severe mitral regurgitation. I think in all of our reporting we need to describe what the lesion is, what the valve looks like, what the etiology is, and the level of the dysfunction as well. And valves are inherently 3D structures. And I think the only time when I really first started to understand valvular anatomy and mitral valve disease is complex is when you actually get a chance to go to theatre and a chance to use 3D. We're so used to looking at it in 2D, but really these are 3D structures we're imaging.
Sorry, can I interrupt for 2 seconds? We've lost the stream. Yeah, I know. I think maybe it crashed.
We're just getting the stream back. Just while we're waiting, I think for, as I said, about spending time in surgical centres where we interact with cardiothoracic surgeons. We're very lucky at Macquarie University Hospital, where we do have a very close association with the surgeons that work there, Professor Michael Vallely, Professor Michael Wilson, and we get a chance to discuss the pathology in depth and review a lot of the images. So degenerative mitral disease is a spectrum. We start off with simple fibroelastic deficiency. Sometimes there's more tissue or leaflets involved, all the way to Barlows. And 3D allows us to accurately identify this pathology. And I think it's really useful to actually see what it looks like in theatre, what a Barlows valve looks like, and what it might look like on 3D. And I'll talk a little bit later about parametric maps, which allow a visual representation of our findings on 3D echocardiography. So clinically, there is a difference between Barlows disease and fibroelastic deficiency. In Barlows disease, you'll see there is a lot of excess tissue. Often the annular diameter is very large, greater than 50 millimeters. Fibroelastic deficiency, there's not a lot of excess tissue. Often it's just one segment being involved, usually P2. They're often elongated chordae or chordal rupture. And also, as Sean mentioned, in Barlows disease, there's often valvular calcifications with thickened chordae tendineae as well. This is a nice example of fibroelastic deficiency. This is an image that I've gone into 3DQ, so the software, and done some manipulation to display the image very nicely, and we see very clearly here of P2 prolapse. Another valve of fibroelastic deficiencies. This is our 2D transesophageal echo, color Doppler, what this valve looks like in 3D, and very clearly you can see that the prolapsing segment of P2 coming out towards you with some ruptured chordae. This is another example. So I think it's very useful to think about what the valves look like in 3D when you're seeing the 2D image, and then thinking about what the pathology might look like, and looking at the surgical specimen. Barlows prolapse, where you often have multi-segment disease, very large segments, large annulus. So this is a nice representation of, once again, with the Barlows disease, often you see them as younger patients, so of prolapsing of a large anterior segment of the mitral valve, a large P2, and that's a sort of very large segment there. And these are all done in routine day-to-day clinical practice without a long time spent processing these images. This is of a lady who's slightly older. It's a Barlow style valve, not as redundant as some of the other valves. I'm showing you this picture to show that we took this image and then we followed it up with a color 3D image to get an idea of where the valvular lesion was. And often you can slow this down offline and go frame by frame to see where the origin of your mitral regurgitant jet is. This is one of the advantages of 3D color. So, can 3D echocardiography accurately predict complexity of mitral valve repair? There have been a few studies on this. So for complex mitral valve repair, it's important to identify multi-segments, if there's anterior leaflet prolapse, if there's a scarcity of leaflet tissue, if there are calcifications, and Professor Vallely is going to talk more about mitral annular calcification. These are very important to identify. A high prolapsing height, especially of the A2 segment, and annular dilatation. And as imagers, I think we now have a duty to be able to clearly identify which valves are going to be more complex to repair rather than a simple repair. So, this leads us to comprehensive mitral valve imaging prior to surgery. We need to classify the mitral regurgitant mechanisms. We need to describe our pathology. We need to be able to assess the left ventricular size and function, and though this isn't on the left ventricle, 3D echocardiography provides superior assessment of LV size and function compared to 2D. Lisa Simmons is going to talk about grading the severity of the mitral regurgitation. It's important to include valve calcification and MAC, to mention annular size, and don't forget the subvalvular apparatus, which best imaged in the transgastric view on 2D, and don't forget the tricuspid valve as well. Measure the tricuspid annulus and other valvular abnormalities such as ASD. So after 5 years of using 3D, what lessons can I give to those of you interested in starting and using it more? We talked about degenerative mitral regurgitation is not just one disease. Now I find that transesophageal echo is much better having an anaesthetist present. Does anyone not use an anaesthetist with their transesophageal echoes? So I find that if you've got the ability to have one, because often these procedures take longer, the patient's more stable, there's less patient movement. I find I have better pictures having a sonographer present, and we do our best to involve our sonographers in all of our transesophageal echo scans, and I think it helps gets better pictures. A slower heart rate is much better for acquisition of 3D images. We don't get great pictures in AF, though we can do good single beat pictures, or if there's unstable heart rate. And we need to spend some time post-processing the images. So to get really good at 3D takes a time investment, both acquiring the images and also spending some time offline looking at the images and getting used to manipulation of the software. This is some really nice imaging that you can do, that you can really do online. It's called, where you look at anterolateral commissural views, posterior medial commissural views, and also look at the posterior scallops. It was adapted from Vegas, which has got a book, Realtime 3D echocardiography, and also using angled views. And this is an example of what's really nice. And this picture here is you see very high posterior prolapsing segment, and you can get really good views of the commissurals. Also important is to differentiate clefts versus indentations. A cleft is greater than 50% of the leaflet, while an indentation is less than 50%. And here's a nice cleft of the anterior mitral valve in a young lady with Down syndrome. And it's really important to identify because clefts can be an underrated cause of residual mitral insufficiency. Parametric maps, which we did a bit in the workshop today, allows us to visually show the valve and show the defect. These are much easier to do with modern iterations of the software. And as these are more research tools that they will start to use more often, where we can actually measure a vena contracta, a 3D effective regurgitant orifice area, a proper anatomic orifice area, and either look at 3D color stroke volume. So 3D requires an integrated assessment, collaborative decision making. It allows us better understanding of pathology aspects, provides indices and views not described by 2D echo, and also has created a common language between the surgeon and echocardiographer. I'd like to thank my colleagues at Macquarie University Hospital that we work very closely with the surgeons. We have very engaged sonographer teams and also the teams in the theatres that help make this all happen. Thank you.
While we're stay here, Jason, for a sec. While we're setting up the next talk, Jason, there's a couple of questions which we can quickly answer. First thing is, somebody's asked me, are these mostly transesophageal 3D pictures? They mostly are.
They mostly are.
Yes. Secondly, is there a special name given to the indentations between P1, P2, and P2 and P3? Are those little? Is there a name given to those things? Or Sean? No.
No, I don't think there's a name.
They're called special indentations. Yes. Okay.
I think it is important to make sure that they're not clefts as opposed to, and it's important to make that differentiation.
And the definition of a cleft is?
Well, greater than 50% of the leaflet.
Virtually down to the annulus, isn't it? Very good. Okay, thank you very much, Jason. Very good talk. Okay.